If you joined us today to hear Dr. Bernard Suter share current information in thinking about males with Rett syndrome, as well as MECP2 duplication syndrome, and to learn helpful resources from your rettsyndrome.org parents of males representatives, you've arrived at the right place. I am Paige Nuez, Director of Family Empowerment at rettsyndrome.org, and our board of directors and all of us at rettsyndrome.org want to thank you for being with us today, for your support and engagement. Continuous awareness and empowerment is critical to our shared success, and I say this both as a parent to a beautiful teenager with Rett syndrome and as your advocate at rettsyndrome.org. We want you to be as educated and empowered as possible as you care for your child and as you speak to others about your child. You can count on rettsyndrome.org to bring you the latest news and information in the field and to continuously push for new and innovative findings. So today we're going to unpack what we know about the clinical presentation of males with Rett and MECP2 duplication syndrome, as well as the landscape of clinical and translational research. We welcome and thank all families, caregivers, clinicians, researchers, and industry for joining us today. Next slide. We believe that information on our rare disorder should be free to all who avail themselves of it, and we want to thank our donors and supporters for their shared belief. Our 2021 educational programming is made possible through the generous support of both Novartis and Taysha Pharmaceuticals. We're grateful for their support, which allows us to connect and empower you with best practices and key information in the here and now. Okay, and next slide. We want to welcome many attendees from the MECP2 duplication community. Thank you for being with us today. We hope you find some really helpful information. And as you go through your journey, we encourage you to stay connected with the MECP2 Duplication Foundation for resources and support unique to your child's diagnosis. Next slide. We ask everyone today to participate in a campaign to help secure federal funding for Rett syndrome research. We need your help. To have Rett syndrome listed as a topic eligible for federal research funding through the U.S. Department of Defense peer-reviewed medical research program. You can help this week. This week only will conclude our letter writing campaign. If you'll visit our website, you can follow the instructions to contact your U.S. representative and U.S. senators today and request them to please support Rett syndrome research in the FY22 defense funding bill. Thank you for taking a few minutes and advocating for research for our children. Next slide. We are gearing up for the Ascend 2022 Rett Syndrome National Summit in Nashville. Designed to unite us as a community, this event will bring together parents, families, clinicians, researchers, and Rett organizations. Together, we can overcome the challenges of Rett syndrome and reach the summit of hope and healing, a world without Rett. So save the date. Please come. We welcome all families, all parents of males and females. There'll be something for everyone. Next slide. Another resource that has come out of our research investment is relevant for males with Rett syndrome and is especially important as we face many different learning and therapy environments right now, online, hybrid, in school. These guidelines will help get everyone on your child's team on board with our communication potential. The guidelines are helpful for both males and females with Rett syndrome and related disorders who are mostly nonverbal. These are great guidelines. Please access them. And we're very excited to make our community aware that we do have a Spanish version available now, and you can access both the English and Spanish versions, okay, in print or electronic. So next slide, I want everyone in the community to really be aware of our Rett Research Ready tool to help you find information on how to be Rett Research Ready, to find information about observational studies, clinical trials, virtual studies, and research surveys. There is something for everyone that our families can participate in. Please scan this QR code or visit our website, rettsyndrome.org. Go to the Rett Research Ready tab and explore away. Okay, so on our next slide, I want to thank you for being with us today. Before we get started, I want to quickly have Kate Ferdinandson come on and talk to us a little bit about her child's diagnostic and clinical journey, and then we'll hear from Ashley so that we can really get ourselves situated about what brings us together today. Thanks, Kate.
Thanks, Paige. So I'm Kate, and my youngest son, Colin, has Rett syndrome. As you know, he entered the world of Rett syndrome shortly before his second birthday. And up until that point, Colin developed neurotypically, with the exception of speech. He has never been able to use his voice to communicate, but he is a great communicator, nevertheless. But it took us another 4 years of searching before we received the correct genetic testing results that told us he had Rett syndrome. At that point, we were under the impression that he was one of maybe a handful of males on the planet with Rett syndrome. And, you know, everything I looked up online, research-wise, told me that at the age of 6, he had already outlived his life expectancy. So needless to say, we were consumed with worry. But then I found a Facebook page created by this incredible mom by the name of Anna McGrath about her beautiful son, Mariano. And she told me that there were other parents out there and they were getting together and starting a group. So I think there were about 8 or 9 families back then. And over the years, the group grew and grew. And, you know, I was able to tap into the wealth of experience and support that other families could offer, which was incredibly helpful and relieved a lot of the isolation I was feeling initially. So during this time, I also learned some things about my son. Like so many other children with Rett syndrome, he is sweet, silly, resilient, heroic, and a little bit mischievous in the funniest possible way. And I know I speak for my whole family when I say that Colin continues to expand our capacity to love every single day. So I'd like to also acknowledge the precious boys that our male Rett community has lost over these past few years and their families. Many of their parents continue to share their wisdom, their empathy, and experience with newer parents to the group. And I just wanted to say that they and their boys will remain an important part of our group forever. So that's really my abridged story page.
Thank you, Kate. I appreciate that. And we are so happy to hear how well Colin is doing. And he is breaking barriers in terms of our understanding of males with Rett syndrome. And we wish him to continue to do well. Ashley, if you'd like to turn on your webcam, we'd like to hear a little bit about Parker.
Okay, so no matter how many times we do this, it never gets easier. Like a mess over here now. So my son Parker is 4 years old, and unlike Colin, he received his Rett diagnosis at 8 months old. So it started when he was 3 months old. My mom, Parker's grandma, noticed Parker was having head drops that weren't normal, but the pediatrician wasn't concerned until a couple weeks later, and Parker had his first 3 grand mal seizures all in the same day. He's never had any since. But that led to EEGs at a Japanese hospital, because we were living in Japan at the time, and staying there for a week, and then flying to the United States to get the diagnosis of West syndrome when he was 5 months old. And because he had the diagnosis of Rett syndrome, they ran a seizure panel, which found his MECP2 mutation. And that's when he was confirmed Rett syndrome at 8 months old. I was then tested and found out that I'm a carrier of Parker's mutation. And so at 6 months old, he started with PT, OT, aqua speech therapy. And just recently at 3.5 years old, he started walking and talking. Parker says sentences now. And sorry, I'm like in my feels. So basically just I know everything online says not good things or whatever, but things are changing and we're finding more boys. So I really just encourage everybody to get in touch with Dr. Suter at Texas Children's Hospital to just get your son's information into the database. That's like #1 thing that I want you to take from Parker's story.
Thank you, Ashley. Kate, Ashley, we really appreciate you sharing the story of your sons. To orient us before we get started with Dr. Suter, our main speaker today. And we look forward to having you join us again at the end of the presentation to share your role as parent volunteer with RettSyndrome.org to be a source of resource, support, and connectivity for all families. So what we'd like to do now, now that we are situated, understanding that we all have our unique stories, and yet at the same time, we have some universal truths about our children and our journey, and that we know together that we are better connected as families, and that we are supremely indebted to our physicians and clinician researchers who are working on behalf of our children for better tomorrows. So right now, I'd like to introduce our main speaker, Dr. Bernard Suter, Assistant Professor, Pediatrics and Neurology, Director of the Center of Excellence for CDKL5 Deficiency Disorder, and Medical Director of the MECP2 Duplication Clinic at the Bluebird Circle Rett Center, Baylor College of Medicine, and Texas Children's Hospital. Dr. Suter serves as an investigator in the NIH-funded natural history study for Rett syndrome and related disorder community, and has met many of you and knows your children and is going to share us. Thank you, Dr. Suter, for taking time out of your busy schedule to share with us the current thinking, most current thinking. I'm going to turn it over to you right now. And if anyone has any questions, just a reminder, go ahead and type your questions into the question field, and we will take some time at the end of Dr. Suter's presentation to go over your thoughts. Thanks, Dr. Suter. It's all yours.
Thank you, Paige. Thank you very much for the kind introduction. So I'm Dr. Bernard Suter, an assistant professor at Baylor College of Medicine and Texas Children's Hospital, where we currently also have a study ongoing on concerning boys with MECP2 Duplication syndrome and males with Rett syndrome. And thank you, Kate and Ashley, for sharing your very personal stories, as which provides a very, very good introduction to my talk. Let me go ahead and provide a little bit of a background to, so I will talk both about males with Rett syndrome and males with MECP2 duplication syndrome, and we'll end the talk with a brief overview of potential upcoming therapies, genetic therapies specifically. And I would like to circle back I will like to give you a little bit of a historical perspective for the individuals, the male individuals with Rett syndrome, because I think it'll highlight why there has been so much confusion in the diagnosis over time, and probably a lot of unrecognized cases as well. Really, I want to point out that a game changer to the diagnosis in that field was the discovery of the gene of MECP2 as a cause to Rett syndrome, obviously at that point for girls. What does MECP2 really do? It's a protein that binds to DNA, specifically to methylated DNA, and regulates the expression of other genes. Predominantly, it seems to be involved in turning off some genes, which is important because that prevents these other genes from making proteins when they during times when they're not needed. It can, however, also activate other genes, and this MECP2 gene is located on the X chromosome, on the long arm of the X chromosome at band 28. This is important background information going forward to in my talk. It is very, very important to realize that MECP2 is really a dosage-sensitive gene. There are several other genes, obviously, but they're in the minority if you compare them to all the genes in our genome. It's exquisitely dosage-sensitive, as you can see in this figure from the mouse work, where you can, at the bottom, you can see increasing phenotypic severity going from left to right. And on the y-axis, you see the amount of MECP2 that you have in the body, in this case, in mice. So what you can easily see that duplication mice that have, roughly 200% are already at a certain severity. And if they have 3 times the amount of MECP2, they're very severe. And a similar fact holds true for those mice that have Rett-like mutations, or Rett mutations really, where they lose MECP2 function. As they have mutations that are more and more severe, their phenotype their clinical picture gets more and more severe. So let me start with the part of my talk talking about so-called male Rett syndrome, and talk to you a little bit about why it has been so difficult to diagnose and recognize. So I'll be talking about the bottom half of the figure I just talked to you about, the mutations that lead to loss of function, 50%, 0% of function of MECP2. And even as recently as 2019, you can see that about 3,900 females with MECP2 variants had been registered in the international Rett base, but only about 60 cases of males had been reported. And in part, it was still believed that the phenotype of the males is predominantly one of a severe neonatal, meaning around birth, encephalopathy as the main symptom. And even another paper by Jeff Newell recognized that there's a lack of clear clinical features, phenotypic features that would characterize males with MECP2 mutations as there is for the girls with MECP2. And even though there are some consistent features, perhaps, they are more variable and less distinctive than in the girls with Rett. So let's circle back to the situation around the 1990s. Really, Rett syndrome clinically had already been defined in 1966 by Andreas Rett. You know all of that. Then there was a publication that made that description available in the English language in 1983. And just about 5 years later, clinicians had found a whopping 1,250 plus cases of girls with Rett syndrome, but 0 males had been described, okay, by the 1990s. And why? Well, why is that really? It's because we didn't know a cause. So it's a very good example why just the clinical recognition may not be enough. People were still tapping in the dark in the 1990s. In the mid-1990s, Hanefeld, for instance, said there's no doubt about the genetic origin, but abnormalities on the X chromosome have been more or less excluded. And as I just showed you, obviously, MECP2 is located on the X chromosome, right? Another the person in the beginning of the 1990s came up with a case description of 2 males that were readily recognized as male Rett, but he said, perhaps we don't recognize the syndrome because males have a completely different phenotype, which is not quite untrue. It is true in the sense, as you will see, in that there is just a much larger spectrum of a clinical phenotype in males with MECP2 mutations. It was really initially thought until the 90s that if there were male cases, that they would be fatal, mostly in utero. So one of the first papers out there about males with Rett syndrome really was, is classical Rett syndrome ever present in males? And Mary Coleman describes a case of a child that very clearly, from our perspective nowadays, has Rett syndrome. Initial normal development for the first 11 months, maybe a little bit slow, but on the average, pretty normal development. And then a loss of skills. So a whole hand grasp, can feed himself, and then gradually lost the skill. Described as being clumsy, having on exam gait apraxia, truncal apraxia, ataxia, and never really speaking. The occurrence of midline hand wringing and clapping stereotypies. So something that somebody who has seen a girl with Rett syndrome would very quickly recognize as having Rett syndrome. And in that same paper, he fits it to the then current criteria of Trevathan and Naidu. And basically, she says the case fits the criteria, the clinical criteria, but the conclusions of the paper even read, without a biological marker, so without the gene discovery, it is impossible to be sure if this patient does or does not have Rett syndrome. In fact, it is possible, they discuss, that this particular case may help us to develop better exclusionary type of criteria, in that this case may just be closely resembling the Rett syndrome and not actually be Rett syndrome. So they were in a huge dilemma in the 1990s, not knowing whether there were boys out there with Rett syndrome or not. Another case that I want to briefly touch upon is another description of a case that I feel is very clearly a Rett individual, right? At the time of description, that was a 5-year-old child who initially had normal developmental milestones until 6 months of age, and then showing signs of arrest, never really reaching walking. Purposeful hand movements were noticed at the 2nd birthday, was microcephalic, and there was no speech. There was some increased tone/spasticity, and there was the truncal ataxia. On top of it, he developed very characteristic midline stereotypic hand movements. And just to remind you, these individuals then had to undergo a huge battery of investigations, getting a CSF draw, blood and urine amino acid profiles, serum lactic and pyruvic acids, ammonia, an EEG and EMG, some lysosomal enzymes, and some imaging studies were all done without a conclusive evidence of what this boy might have. Here is just another example from the time point of 2 more boys that are demonstrating fairly classical Rett signs and symptoms. These are show you the boys that they actually were able to describe in the literature in the 90s up until the very end of the 90s that appear fairly classical in phenotype. No descriptions of non-classical phenotypes, right? And then the gene discovery, along with the development of technology that allowed for screening large populations with less characteristic phenotypes, such as generic intellectual disabilities for genetic mutations, really rocked the field. And you can see that prior to 1999, there had been a whopping number of 8 male cases that were reported, right? And since then, up until 2015, 50 more cases popped up. So the discovery of the MECP2 gene as being linked to Rett syndrome has greatly sped up the discovery of male cases with Rett or a variant phenotype. Now, that is undoubtedly part of why there are fewer cases recognized than in girls. And in part, it may also be due to the mutational mechanisms that lead to a mutation in MECP2, which is slightly different from the girls, or not slightly different. In girls, typically the mutations are really, they do occur de novo, meaning in the girl, and that is affected by Rett syndrome, and are not inherited, and they arise from the sperm, the rapidly dividing germinal cells, and this mutated sperm will only produce a female child. Okay, MECP2 mutations in males occur much more often from the less common maternal inheritance, or perhaps as a de novo event in the mother that is then passed on to her boy. Very rare causes are somatic mosaicism or chromosomal abnormalities. I'll talk about that in a second. On this huge figure, I just want you to recognize that in this case collection from 2007, right, you can see that the de novo mutations in MECP2 that are common in girls are really uncommon for the boys with MECP2. Here is a case, here's a case, then I have to go down much further for some other de novo mutations. All right. The rare, and then there are two groups that contribute, but contribute a very low number of cases to apart from the maternal inheritance, and that is individuals with 2 X's, but who have sex chromosomal abnormalities such as Klinefelter, in somatic mutations that lead to a mixture of mutation positive cells with normal non-mutated cells, and lead to an individual who is really mosaic, contains different DNA within the different cells of the body, and therefore has a good degree of normal cells in his body, which will obviously, we think, buffer against the bad effects, the deleterious effects of the MECP2 mutation. So in a genetic sense, this buffer may be, although mechanistically not the same, may be a similar effect in these mosaic individuals as the mosaic that occurs through X chromosome inactivation in females. So here is just a graphic description that, you know, when basically as a multicellular organism is being built, right? Cells go through cycles of cell divisions, and if a genetic change comes along the way, but later on, only the lineages from that cell will carry the mutated, in this case MECP2, in their body, and be surrounded by other cells that carry normal normal MECP2 in content. How often do mutations in the MECP2 mutations of MECP2 occur in males? There is one study from 2007 that has ventured an estimate of roughly 1.3 to 1.7% of males with intellectual disabilities, and this arose from a large screening effort of roughly 2,500 males, where they found 45, 46 individuals that had mutations with MECP2. To compare to that, the most common cause for intellectual X-linked intellectual disability in males, familial inherited cause is Fragile X, and that's roughly doubly as common. What types of mutations do occur in males with Rett syndrome? Let me briefly go back to that overwhelming figure. As you can see, similar mutations to the girls occur: missense mutations, frame shifts, nonsense, in-frame deletions. And you can group these mutations into basically affecting individuals that have clearly Rett-causing mutations, then individuals with mutations that do not typically cause Rett and are associated, let's say, just with intellectual disability, and individuals that carry MECP2 variants of uncertain significance that could be benign or could have a deleterious effect. We just don't know about them yet. So let me talk about those three groups going forward, these three different mutation groups, as they have been delineated very beautifully by Jeff Newell and others in a cohort from the natural history study that collects natural history, clinical signs and symptoms from males with MECP2 mutations, and they also, by the way, collect biosamples if anybody is interested in contributing there in that effort to further understand male individuals with Rett mutations. So he basically did an analysis of 30 males with the Rett mutations, and comes to the conclusion that I mentioned before, that still to this date there is a lack of a clear clinical picture in males compared to the females. However, there are some consistent clinical features, albeit they're more variable and less distinctive than in females, right? And on the average, we still think that in general, males with MECP2 mutations seem to display a greater severity than females with Rett. So can you, on the average, can you recognize distinctive Rett features in males with Rett mutations? And the answer is very clearly yes. In a study from 2015 from Raiko et al., who basically gave an overview of all the males known to date, you can see that very clearly many of them, say 83%, have this poor coordination, abnormal gait trunk movement that you can also see in Rett girls, the consortium diagnostic criteria, right? the language features, possibly a decelerating head circumference, a loss of hand skills, and a seizure disorder are present in a majority, actually, of the population that he analyzed. I have to give you one word of caution. He analyzes absolutely everybody that had been published. In a few cases that he groups in there were due to mutations in Rett MECP2 related genes, CDKL5 and FOXG1. So the percentages may not be absolute, but very close if we only look at the MECP2 mutations. So if we go back to the analysis, the newest analysis that I'm aware of by Jeff Newell et al. From 2018, 2019, we have a correlation, a genotype-phenotype correlation for the three large groups. One group being outside of the mosaic, rare contributions of two cases that very clearly had classic Rett. There were 28 cases, with a majority having Rett-causing mutations, meaning mutations that we know cause Rett in girls. Then a few cases, I believe 9 cases of the individuals that have a mutation that are likely causing a phenotype, a pathogenic phenotype of intellectual disability or even an encephalopathy. And then in that study were also 3 individuals with mutations that we don't quite know what they're doing. And even then, if you classify, for Rett causing in girls, clearly Rett causing mutations, likely more general pathogenic mutations and uncertain mutations, you will see that there is a wide variability in presentation. So first off, 16 cases out of the 30 had Rett-causing mutations in MECP2, and 4 had the infamous neonatal encephalopathy with a very severe course and potential early death in the first years of life or first year of life. Then 5 each had either a progressive encephalopathy, or the other 5 had a much milder cognitive impairment course, and 2 fulfilled criteria for atypical Rett syndrome. So we're very much in the group of Rett syndrome, recognizable as Rett syndrome. This is the detailed listing of the features. You can see that the individual symptoms in that group reach from markedly impaired spoken language, but a large variability there. Some had no vocalizations, some had vocalizations, some 1 achieved words, 3 went to the babbling phase. 9 of these 16 had a clear history of regression, so not all regressed, right? Many of them had predominantly loss of hand skills. 7 of the 16 had hand stereotypies, and gait presentation varied greatly. And many of these individuals actually had seizures. So these were the individuals with the Rett-causing mutations in females with those mutations. And you can see this variability being reflected in that the overall clinical severity, as measured by the Rett Clinical Severity Scale, was very variable, with scores from 12 to 42, where the maximum is really 45, so all the way down to 12, right? There was some correlation to actually where the individual mutation on the gene was located sort of split up by the location of codon 270, 271. This is a very important point in the gene for specifically also for the females with Rett syndrome, but I won't go into detail there. So let's see how variable the second group, those boys with likely pathogenic mutations, are. And you will find that amongst those 9, 2 had this very severe neonatal encephalopathy, and then 2 had a progressive encephalopathy, and maybe more had cognitive impairment. So it's sort of maybe potentially hinting at that this group may have a little bit of a milder severity overall, but the case number is very, very low, right, to make any firm conclusions. 0 actually had atypical Rett. I'll actually skip that slide. And then what about the uncertain variants? What I would like to point out there is that all of the 3, there were only 3 cases, but all of them had quite a number of the so-called Rett supportive criteria, which are not the gait, not the hand skills, importantly, not the regression. One had a regression, but only limited regression, a transient loss of social smile. So possibly hinting at a slightly milder phenotype, but again, that is what we know from 3 individuals so far. So the conclusions from this extensive longitudinal study of males with Rett syndrome in the natural history, NIH natural history study, is that actually males who have clearly Rett-causing MECP2 mutations are more commonly represented in the group that has this very deleterious neonatal progressive encephalopathy with early death. And the other conclusion is that if you have, if you are a boy and you have MECP2 mutations and you fall into a category that resembles, that is on the spectrum of Rett phenotypes, and you have atypical Rett, right? You will have clinical features of that, but they are typically displayed less frequent and more variable. Specifically, the hand stereotypies and the periodic breathing are less represented in that group than they are in the females with Rett syndrome. And these are very characteristic features of Rett syndrome, such that when they are not present, a provider might not easily recognize that you as a boy fall onto that spectrum of male with potentially Rett syndrome. So in order to then establish a little bit of going forward, a little bit of clarity amongst all of the phenotypes, all of the clinical pictures in males that have MECP2 mutations, Jeff Newell really suggests in that paper that those who do not meet criteria for Rett like the girls do, right, either typical or atypical, should really carry a diagnosis of cognitive impairment or progressive encephalopathy with a MECP2 mutation, or in the extreme case, neonatal encephalopathy with a MECP2 mutation. In the term, in the other term used in that group should be male Rett encephalopathy if you completely meet criteria for Rett syndrome, meaning having clearly identified pattern of regression. Without that, you can't say that an individual has Rett syndrome, and displaying at least 2 of the 4 main criteria and at least 5 of the 11 supportive criteria. And of course, you need to be male and they have a MECP2 mutation. So I hope that this brief overview tells a little bit of a story why to this date it is still very difficult to clinically recognize somebody as being a male potentially with Rett syndrome, and in that really the majority of diagnoses at this time will probably be via the avenue of a molecular diagnosis for a more variable phenotype. I now want to go on to the second part of my talk, where I want to talk about how does this differ from males with MECP2 duplication syndrome. So now I'm coming to, for this dosage sensitive gene, I'm coming to the top part, mutations that cause the increased MECP2 function and therefore increased severity of a clinical phenotype. So there again, it is important to point out that MECP2 duplication syndrome is really genetically defined, not clinically defined at this point. Its prevalence, again, is estimated to be about 1%, so maybe actually slightly lower, of male patients with unexplained X-linked intellectual disability. Okay, very important to note for that syndrome is that MECP2 dosage correlates with severity. So triplication patients have a really severe phenotype in that syndrome. There are good mouse models for this syndrome, in that the doubling and tripling MECP2 in the mouse models reproduces really all core phenotypes, which is important for the therapeutic part of my presentation. And it is also important that these so-called duplications are really very large stretches. They go way beyond just the MECP2 gene, right? In the males with Rett syndrome, it's a mutation that affects the MECP2 gene, right? In the duplication males, the duplications span over many genes, and it is important to know, however, that the smallest common region of genomic overlap is sufficient to cause this syndrome. So what you can see here very briefly is that these duplications are these red bars. So these are different cases of the males with MECP2 duplications. And they have duplicated regions that vary greatly in their extent and involve greatly varying genes. But there is one common region of overlap here, shown here in the middle, that includes the MECP2 gene and IRAK1 gene. And MECP2 gene is really the one that is dosage sensitive and is thought to lead to the clinical picture. It is also worth noting that these quote-unquote duplications are in truth typically quite complex and may incorporate little stretches of DNA that are triplicated, for example. So what are the core features of MECP2 duplication syndrome? And I'll go over these fairly quickly for the sake of time. And you will see that there is an overlap in the core features between individuals with duplication syndrome and the individuals with male Rett-like syndrome. So these individuals typically have hypotonia at birth. They're very floppy, very low tone, may may actually lie there initially in a frog-legged position, having trouble to roll over, also having trouble with feeding and swallowing, which we will get to. They certainly have gross and fine motor delays, just as the boys with the Rett syndrome. Their onset of walking, for instance, tends to be largely delayed, and they may not develop a full spectrum of hand skills as neurotypical individuals do. They typically have moderate to severe intellectual disabilities, and their speech, just like the male Rett individuals, is oftentimes absent or just or rudimentary. Some have a few words, but not the majority. And interestingly enough, they typically develop spasticity, especially in the lower extremities with time. So they go from the generalized hypotonia to an increased tone, especially in the lower extremities over time. And with that, they may also develop scoliosis and other musculoskeletal issues. Most of them will have functional GI issues, constipation, etc. And many of them will have feeding and swallowing issues. Epilepsy is is a major feature, and the epilepsy can become devastating and debilitating, especially in the teenage years. The onset of epilepsy can be in childhood age, but then it is progressive and can become really severe and even restrict lifespan. They interestingly are very prone to infections, predominantly pneumonias. Some have recurrent urinary tract infections, but the pneumonias are a very characteristic feature of the disorder, in that maybe a mixed picture of aspiration pneumonia and infectious pneumonias. And they typically undergo a period of late regression that often coincides with a worsening of the epilepsy, oftentimes in their late teens, the early 20s. And it is thought, though there are certainly outliers, that this syndrome leads to premature lethality in the second to third decades. So as you could see, a lot of these features have an overlap with the quote unquote inverse, it's not really inverse, syndrome of loss of MECP2 function. And that has implications for the for treatment, important implications for treatment. So what are avenues for treatment? And there are a multitude out there, and I will highlight some and not go into too much detail at all with the others. Largely, you can think of treatment approaches as being subdivided as symptomatic, so symptom-oriented treatment, and therapies such as physical, occupational, speech therapies. And then you have the two large groups of targeting modulators, targeting downstream MECP2 targets, or directly targeting the MECP2 gene with genetic interventions. Here is an example for Rett syndrome, for girls with Rett syndrome, of the multitude of approaches that have already been undertaken in order to treat at least aspects of Rett syndrome, targeting, for instance, neurotransmitter systems, or targeting growth factors such as IGF-1 or BDNF. And then the group of targeting the actual gene at the level, either at the gene level or the RNA or protein levels. And I'm going to skip this part. So one example of these neuromodulatory treatments is the trofinetide study, which is still ongoing, which is really based on mouse work on recombinant IGF-1 growth factor, which in the mouse model was actually quite successful. This agent mecasermin restored synaptic spine density and synaptic transmission, but a clinical trial with very small number of only 12 girls did actually not pan out to show improvement. In order to bring that to a larger scale, there is now a study underway. We're well into it with trofinetide, which is just the terminal last three peptides of this IGF-1 molecule that has proven beneficial in the mouse model and in the first phases of the trofinetide study. So that would be one example of neuromodulatory growth factor treatment, right? And then when you come to gene therapy first for Rett syndrome, right, you have to realize, yes, theoretically it is possible. There is a proof of principle mouse model out there that dates back already to 2007, where MECP2 could be switched on and off as reversibly activated. And when it was switched off, so mice born with a gene turned off developed features of Rett. And then when that gene was turned back on, the mice recovered. And they, furthermore, studies showed that you could give it systemically in the mice and improve the mice, right? But you have to bear in mind that there are huge hurdles to this, right? Introduction of another copy of the MECP2 gene into an organism could raise the amount of MECP2 to the point of actually converting it into the opposite syndrome, MECP2 duplication syndrome, if you add too much MECP2, right? And so you have to have, for Rett syndrome, you have to have an avenue to gauge that you deliver just enough MECP2 to rescue those cells in the body that do not have functional MECP2, but you don't cause havoc in those cells that actually do have functional MECP2. What is a promising approach for a MECP2 duplication? Obviously, you're not going to pile on even more MECP2 in MECP2 duplication mice. There, you can use a genetic strategy that proof of principle was delivered in 2015, in that MECP2 duplication mice could be rescued by a construct called antisense oligonucleotides by giving those. What are those? So if you think of your DNA, right, double-stranded here, two strands of your genetic material, the DNA is converted into a single strand before it is translated to make protein, and so it's converted into what's called messenger RNA, and this message is then translated into the proteins, which are the true building blocks of our cells, right? If you catch the single-stranded messenger RNA stage through which the process needs to go in order to build the protein, and you basically add these antisense little fragments. Oligo means few, basically, few nucleotides, right, that will pair to the single-stranded messenger RNA. That construct will be degraded and destroyed. So if you give just the right amount of the antisense construct here, you can selectively destroy some of the strands of the RNA, and therefore the production of too much of the protein. That this concept works, as I said, was shown in 2015. They were able to rescue motor, memory, synaptic plasticity, huge effect on epilepsy in these mice, and also correct gene expression changes. And they just followed it up in 2021 with a better mouse model that now carried two human strands, alleles, rather than one mouse and one human strand, because after all, you want to target, an organism that has two human strands. So I will finish up by then, if we look at genetic manipulation, you can try to replace the gene in Rett syndrome. You can, quote unquote, knock down the amount by using antisense oligos in duplication syndrome, and you can try to genetically edit the gene with this CRISPR-Cas technology, which has its own problems specifically related to the MECP2 gene. But before we can do genetic therapy successfully, there is a very, very crucial need for biomarkers. So first off, when you give genetic therapy, you will be giving it, with a worry that you may be over-treating, as I just stated. And then, can you rely on clinical phenotype, on the clinical presentation alone to catch that? The answer is no, because there is this significant overlap between too much, the MECP2 duplication syndrome boys, and too little, the male Rett-like individuals, in motor impairments, in impaired communication, in the intellectual disability, in GI function, right? And the time course of change that you induce on the genetic side may be much faster than the clinical picture changes, right? In order to learn to speak, that takes anybody quite a while. To run takes quite a while. So that will lag behind the changes that you do on a molecular basis, induce on a molecular basis. And so you need to catch those changes earlier to prevent that you're not over-treating. So that brings me to my final point, that we currently have the Ionis Pharmaceuticals biomarker study ongoing at Texas Children's for the males with Rett syndrome and males with MECP2 duplication syndrome, in order to search for a biomarker that will allow us to catch those changes much, much earlier. The initial goal of the study was to enroll 10 individuals each. The study has recently been capped at fewer individuals. No cause to panic. It's just a readjustment by the sponsor, with slightly less individuals, 16 in total. And we are looking at clinical, neurophysiological, and molecular biomarkers of all sorts. And we're taking several time points over the 2 years that the study is conceived for, because we want to study how these clinical, neurophysiological, and molecular biomarkers change with progression of time and how stable they are. And with that, I would like to thank you, end my talk, thank the families extremely much for their participation in this, for their eternal patience in this at times really confusing terrain. I would like to thank you, the Rett Syndrome organization, for giving me the opportunity to speak here and in general, for being there for anyone affected by these disorders. And a huge thank you for all of my colleagues without whom obviously this amount of understanding could never have happened. And this is my final slide, showing the Rett Center at Baylor College of Medicine, Texas Children's Hospital. I have a very astute and active is not the right word, but great colleague, Davud Pehlevan. And of course, there is the long-term director of the Rett Center, Dr. Dan Glaze. Dr. Mutil is working with us on the GI side. We have a dietitian that helps us on the GI side and for the ketogenic diet for seizure treatment. And two excellent nurses are part of the picture, Moraya Marculese and Mohamed Samaruddin. Thank you very much for your time and attention.
Dr. Suter, thank you so much for an incredibly rich presentation. I know that I have heard this talk many times and I learn something new each and every time. So I encourage families who are new to this information or have trouble understanding it to remember that you will receive a link to this recording and you can go back, rewind, revisit. This information is not something that many of us came to this diagnosis having a genetics background. So we're all trying to get up to speed really quickly. So thank you very, very much. Transitioning off of the genetics, clinical presentation, and research information, we know that there's much more to life, living with our children with quality of life issues, accessing services, equipment, IEPs, quality of life issues that we all have to deal with in our day-to-day lives. And I'm really happy to bring back to screen Kate Ferdinandson, who's going to share a little bit as our parent volunteer representative for males, who's going to give some advice and some information that should help you along on your journey. After Kate speaks, we're going to hear from Ashley, and then we're going to go to QA. So this is a good time. If you have questions lingering in your mind that you have not submitted, go ahead and submit them in the question queue. If we don't have time to get to it today before the conclusion of the webcast, we will develop a PDF with our panel of speakers and get that out to everybody who registered today. Okay, so thanks so much. Kate, we'd love to hear some information from you about support resources.
Thanks, Paige. So there's two groups currently that I know of for boys with Rett syndrome and men, because we have plenty of young men with Rett syndrome too in our group. One is a public page on Facebook called Boys with Rett Syndrome Support and Education. And that's for the public to go and share resources about boys with Rett and men with Rett. And then there's a private Facebook group just for the family caregivers, mostly comprised of parents and some family members who are involved with the daily caregiving of their Rett children. And I'm happy to say that this book has really, I just want to point out, this book is I don't know if you can see it. It's called The Rett Syndrome Handbook by Kathy Hunter. I found that probably one of the most helpful things, resources that I've been able to kind of go back to, and it saved me a lot of time over the years. I'd also recommend the Rett clinics if you haven't already connected with a Rett clinic. I think that you getting there and talking to specialists who understand the complexities of Rett of course, is one of the most beneficial things you can do for them. And I would also, advice-wise, I would say to any parent dealing with Rett, put your own health on your list of priorities, especially your mental health, because as we all know, the road is long, and we want to make sure we're not pouring from an empty cup, as they say. And I guess my final piece of advice to any parent of a child with Rett syndrome is sometimes you just need to stop being your child's care coordinator and just enjoy your time with them. And whatever it is, if it means you skip therapy one day and you go sit in a park and watch the ducks with them, I hope you do that. I hope you get to stop and enjoy your child a little bit, because it can become like a hamster wheel sometimes, trying to get all the therapies in. And that's it, really. So reach out to me if you're a family member and you want to connect.
Thank you, Kate. We really appreciate you committing to be the representative in the mail for males with Rett syndrome, and for sharing the resources where families can get into forums to speak with each other about things that are unique to having a male with Rett syndrome. And we also encourage families to know that you're a community within a community. So please, please join all of the family forums for Rett syndrome and speak about our children. There are so many things that we all have in common, whether our child is a son or a daughter. And speaking of letting love thread throughout all of our advocacy efforts with our kids, I would like to hear some things from Ashley. Ashley, thanks for bringing on your webcam.
So mine's more like, I guess, just advice, like definitely contact Dr. Suter at Texas Children's Hospital if you're able to make that trip to see him. Start low-tech communication early. So something that really helped us was I labeled everything in the house with a PEX card. Everything had a card on it. And Parker started pointing to those, and then it made it easier to transition to actually using like ProLoad on his tablet. And start that just as soon as possible. Sensory play all the time. I feel like it really helps Parker regulate his attitude and his behavior if he can have different type of sensory activities to let out some of that, I guess, like anxiety. Hype up your child's strengths, because if you don't talk about your child's strengths and what they're good at and you feel like they can improve at, then who will? Because no one knows your child better than you. And trust me, people will probably look at you like you're crazy, but don't even worry about it. And then something that has been super helpful, just especially during the pandemic, find a park with adaptive modified equipment so that, like Kate was talking about, on the days you skip therapy, you have a place to go and hang out, and it's always there, it's always open. And that's all I have.
Ashley, thank you. And really, the two of you, please give your kids a big hug and thank them for letting you take time out of being with them to help other parents in the community. It is these connections which really enable us to get through the tough days and celebrate together achievements and support each other during the hard days as well. Okay, so in the remaining 15 minutes, we're going to go to QA. So I invite Dr. Suter and Ashley and Kate, if you would, please turn on your webcams. We have quite a few questions that were submitted at the time of your registration, and we have some questions that came in during your presentation, Dr. Suter. So we do have 10, 15 minutes to go through these questions. And again, if we don't get to everybody live today, we'll do a PDF, a QA follow-up, and this certainly won't be the last time we're together. So we can have another live session, and everyone, we can all meet up in Nashville in April 2022. Yay, in-person events coming back, we hope, and really have a chance to spend some time together then. So this is not a one and done opportunity, but let's see what we can get accomplished in the next few minutes. Dr. Suter, most of these questions are going to be directed to you, but Kate and Ashley, please feel free to chime in if you have something to add. Okay?
Okay.
All right. Thanks for a wonderful presentation. I'm going to go in order of that questions were submitted, because I feel like, you know, early birds should get a little bit of a priority. But some of this might have been answered in your presentation, Dr. Suter, so you can just say that in the interest of time. So parents really are trying to get their head around the differentiation between a male with Rett syndrome versus what is classically known about classic Rett syndrome in females. So the regression period is really hard to understand for anybody, but we have a parent who's really trying to understand, do the boy's condition deteriorate over time? And does what has been achieved remain, or would parents expect to see that regress?
So I think from the little that we really know, I will answer it from the background that I have in general in Rett syndrome, in that it is entirely possible that you have a regression and then a stabilization of a stabilization phase. And I sort of understand the question as more directed towards later years of life. I think what we find very commonly in clinical practice is that a lot ties in with the general status of health, which is very often determined by their epilepsy and their seizure disorder. Whether now one causes the other is the huge multi-million-dollar question. But the continuation of regression what I'm saying may very well depend on how other core features behave, such as the epilepsy. I don't think there is one answer that would fit all. There are certainly cases where the regression will stabilize and skills can be relearned from there.
Thank you. That's the spirit of optimism that we wish to have. The sky is the limit with our children, and never give up. Okay. We have a question about gene therapy trials. And do you anticipate including males with MECP2 mutations and normal karyotypes in these trials? Do you envision that?
Normal karyotypes, you said. Okay. So I would be hesitant to expect that pharmaceutical companies will start off, unfortunately, including boys with Rett mutations, because they'll much more likely go and study effect of genetic intervention in girls in a very clinically defined classic Rett syndrome female picture before they open up to the possibilities of starting to investigate the effects on boys. This is thinking along the lines of the genetic therapy that I envision, that are sort of burgeoning and probably somewhat close, certainly not in months, but somewhat close to first trials in female Rett syndrome, right? I'm not sure whether there may be genetic interventions that may be conceived specifically for the boys. I can't talk for those. I'm not aware of any. Mm-hmm.
Okay, thank you. This information is definitely emerging and changing over time.
Yes. Mm-hmm.
Do you anticipate that any of the drugs currently in trial for Rett syndrome females to be possibly beneficial to treating males if they make it through phase 3 and become approved drugs for prescription?
Oh, absolutely. I would see specifically also the neuromodulatory, the growth factor approaches, trofinetide, for instance, the more quote unquote non-specific in the sense of not as tightly linked to the XY versus XX situation. The neuromodulatory neurotransmitter trials, the growth factor trials may, if they make it through phase 3 studies, may very well have benefit for boys and be useful for males with Rett syndrome.
Okay, thank you. And do you see that this would bear true for those with mosaic presentations as well?
So I would absolutely say again, for the more for the neuromodulatory group, right? Probably a little bit more difficult to determine for the genetic interventions. Mm-hmm.
Thank you. And then we have some questions on clinical management.
Although, sorry, can I loop in to that? In a sense, of course, I take that back partly because females are mosaic, right? Just by nature of their X chromosome in activation. So in bearing that in mind, a genetic approach that is able to very diligently target the amount of restoring MECP2 function may actually work for mosaic males. Mm-hmm.
Okay. Thank you. I'm sorry, one more research question. Do you feel, or are you aware that is there any significant rationale for starting trials in boys for them to be a subset because there is less risk for the overexpression?
I'm not sure that I could see the less risk aspect. So the answer there is no, as far as I would understand it. What may be true is that currently we're undertaking this study, this quest to find a biomarker, and that quest of the finding the biomarker is, after all, currently done in boys with too little MECP2 and comparing that with the boys that have too much MECP2. And so with the help of that biomarker, if that is already established, there may be a benefit of the targeting treatment in that group because we know that that biomarker exists in the boys, right? Conceptually, so on the other hand, conceptually, just from the perspective not of the biomarker guidance, but on the genetic treatment part, I do not readily see an advantage. Mm-hmm.
Okay. Thank you. And again, we will pay attention as new information and thinking is emerging. Mm-hmm. In the interest of time, I'd like to move over to some clinical care questions because I think these are really important in getting through today. And we have families who have asked if there is a connection or a correlation between male Rett syndrome and immunodeficiency.
Not that I'm aware of. The male Rett syndrome, no, not duplication syndrome. There have been several leads, albeit several, with the emphasis on several, on immune dysfunction for the duplication boys, right? For the male Rett, I'm not yet aware of that. Mm-hmm.
Okay.
We
in the
do.
Population.
Oh, sorry. Let me intervene there. A large part, please bear in mind as a parent that a large part of the quote unquote infectious picture may also have a contribution from musculoskeletal issues, low tone, maybe reduced strength of clearing secretions, etc., having profound scoliosis at time that prevents anatomically a very good clearance of secretions, etc. in those issues, you can find obviously you can, as I spoke about, you can find in males with Rett syndrome as well.
Okay. So that's important information to differentiate immunodeficiency versus really some outcomes of impaired breathing, frequent pneumonias, the need for ventilators due to almost motor, the low tone and motor impairment.
Yes, correct. Yeah.
Okay. Now, with the severity of that, we do have a current issue question, which is with the severity of some of the respiratory issues that we see, what are your thoughts about the incidence of COVID? And do you think that males with Rett syndrome should be vaccinated?
Yeah. On the whole, I have information for females with Rett syndrome, and I have information for duplication boys, and actually also information for CDKL5, all of which, share significant overlap in general, broadly speaking, with boys with Rett mutations. And in the current guidelines in our Rett centers is really that the risk of catching COVID and catching a severe presentation with COVID is a greater risk than the risk of getting immunized and having side effects from the immunization. So once that is available for children, and especially speaking for the Pfizer and Moderna vaccines, where you do not expect, you're not introducing the virus, right? I think the clear guideline should be towards vaccination against COVID. There may be individual circumstances that, in an individual case, you still need to discuss it with your local provider or your expert provider that would prohibit, if your child on top of a MECP2 condition has an immunodeficiency, etc., you will need to discuss that prior to the vaccination. But broadly speaking, the general guidelines is in favor of vaccination, because we have had individual cases that were very severe to the point of death. So, yeah.
Okay. Thank you very much, Dr. Suter. We have some questions about really kind of in our last minute or two. We have kind of three clinical care questions. One is about dystonia and spasticity, another on seizure management, and then another on the potential for verbal language, and if we can expect that to emerge once we get control of some of these other medical issues like seizures in males. Those are three big topics. We can end on communication, because we can come back and talk about maybe Ashley and Kate's experiences and some of the support materials we have.
Okay. So would you like me to talk a little bit about management of tone and spasticity first in the boys? I think that is an absolutely crucial component. As I pointed out, typically those issues tend to be progressive for a while, with scoliosis, creeping up more and more severely on you in your teenage years specifically, but even before that possibly. And pardon me, I will actually need to decline that call. That's a fellow looking for me. I should have been more verbal. Anyway, so anyhow, the musculoskeletal complications cannot be underestimated, and treatment should actually in large part be guided by a physical medicine doctor, a specialist in physical medicine, in order to tease out, really fine-tune the treatment of dystonia versus spasticity, and address the scoliosis longitudinally, to make sure that you as a parent don't run into a situation where the scoliosis has progressed so much that other critical body systems, pulmonary function, cardiovascular function is impacted by the scoliosis. There's a broad range of therapies out there, from medicines that help address tone, to orthoses, to spinal corrective surgeries, and they can guide you when is the appropriate time to do each of these interventions. Is that along that page, along the lines of the questions that have accumulated?
Yes, thank you. It is a big topic, but I think that pointing families in the direction of a PM&R specialist is really good advice, and manage it longitudinally. Okay, thank you. Do you have anything that you can comment on about seizure management and obtaining seizure control?
What I would like to emphasize that I've seen in Rett syndrome, certainly, that there are phases very often, that there are phases where seizures, you know, even with intervention, medical intervention, there are years of life where the seizures get worse, and then there are stretches of time where they may not as prominent. There are certainly individuals, specifically also within the group of males with Rett mutations and the duplication boys, where seizures become what we call medically refractory. But on the what I'm saying is, until you are certain that you are at that stage, there is certainly hope and the need to try to very aggressively fight seizures, because there may be stretches where the seizures are not as prominent after a year or two, or maybe a couple of years, where they're more prominent. Okay, so it is not necessarily a linear course with the seizures of them worsening and worsening and worsening. Yeah, that nobody can predict that. And then I would, for these syndromes, I would very heavily recommend that you visit with a specialist that is an expert in seizure management, because very often, let's say, non-first line seizure medicines and additional supportive therapies, such as the ketogenic diet or vagus nerve stimulation or avenues, need to be sought on top of just your first anti-epileptic drug. So I would try early on, in order to establish this continuity of care and longitudinal understanding of your son's epilepsy by the provider, I would early on visit with an epilepsy specialist. Okay.
Okay, thank you. I'm going to sneak in one more question before we move to communication and the emergence of spoken language. Okay, because I think this is really important, and you touched on a little bit earlier. We have some families that have asked about genetic counseling. So you have a child, a male with MECP2, parents and other siblings. Should they pursue genetic counseling?
So especially for the males with Rett or Rett-like mutations, we heard that it is very often inherited, right, from the mother, whether she carries symptoms or not. So it may be something where, for sure, parental testing, but even maybe sibling testing is indicated. Yeah. I don't know whether that answers the question. And it would be a first order. So if your child gets tested genetically, it may be through a much broader spectrum, genetic screen, chromosome microarray, or a whole exome, or even whole genome test. And it is possible that for then follow-up testing, you can restrict it more to the mutation that you already have found in your boy.
Okay, and in general, if you have other children, right? Generally, in general, they should seek their own genetic counseling when they reach childbearing age. Is that right?
Right.
As opposed to, right.
Yes. Yes, correct.
Unless you see something that indicates that there might be some underlying issues. Yeah.
If the mother has been tested, Dr. Suter, and does that matter, as far as the siblings needing testing? Like if the mother of the male has been tested and was negative,
was negative, yes, of course, that then has an implication that you made. I mean, then it is not. If both parents have been tested, right, and are negative, that has implication that is not inherited, and then the siblings do not necessarily need a genetic screen. Okay. If they don't have symptoms, right? I mean, there might be the very oddball case where, spontaneous mutations occur in several individuals. Yeah.
Okay. Okay. I think the closing topic that we would like some clarification on and some guidance from you, if possible, is the emergence of communication and communication abilities in the male population, which really influences the direction of speech language therapy, as well as IEPs and what you pursue in school. So Dr. Suter, if you could give us your medical advice, and then Ashley and Kate, if you would like to bring us back to what's going on with your kids. I think that might wrap us up for the day.
I would definitely advocate for, so we know that our kids are very social, right? We've heard it from the both of your family stories earlier on, and they're individuals that want to communicate, right? So I would very heavily advocate for speech language therapies and therapies early on. There are certainly more and more avenues for augmentative communication emerging over time, and eye gaze devices are only one part of the picture. The devices that are more suited to reaching and touching in order to selecting are getting refined. So in general, the avenues for communication therapy are improving. So I would get a speech language therapist on board very early on, if possible.
I definitely experienced that myself, and that my son's diagnosis came a little later. And we were sort of trying different methods that would not have been quite as helpful for a child with Rett syndrome at that point in the early years. So I think that sort of added to his frustration. So my hope, is that future kids will be able, as awareness gets out there and screening is more prominent for males, that's one of the benefits of awareness, is that, people, doctors, first line physicians, whether it's a pediatrician or a neonatologist, is going to be able to screen for Rett a little easier, and we can get that communication going at an earlier age. I mean, at this point, my son's communication is, we have him now in a program that's much more robust and aggressive with the communication. He's got low tech, he's got high tech. And I think now, I mean, he's 13 and we're seeing a lot more interaction with him. And I do see a slight decrease in the self-injury because of it. So, that frustration is a little bit less. So, any way we can do that, we're looking for that too.
So just like Kate was saying, Parker did benefit from being diagnosed so early at 8 months old, because we were able to target like his Rett needs, what he was going to be able to do or not do, or anticipate that a little bit better. So like I said, I literally labeled everything in the house, and I just kept any type of communication open to him, whether it was text cards or using Prolo to go, or just making my own little sheets and just leaving them on the floor for him to find them. Just giving him every single opportunity. And at first it just started with him pointing to stuff. Just in 1 year, he went from pointing to stuff to speaking sentences. And I think school helped a lot with that, because he did start going to full day pre-K this year. He loves it. So definitely just having a lot of options and starting as early as possible.
Great. Thank you. I think nothing tells a story better than a real life example of success, and getting care teams on board early and often, and exploring all avenues, low tech, mid tech, high tech, and hopefully at some point fine motor and spoken language will emerge. That's a very encouraging, exciting outcome that I hope for all of our children as we have more therapeutics come on board. But really where it starts today, get your hands on the communication guidelines, apply it in your life. There's really practical information that is relevant to males as well as females with Rett syndrome. Okay, well, I know that we could spend the rest of today, multiple days together, sharing our stories, talking about how to participate in research, how to advocate for our children, but really it comes back to each and every one of us to attend sessions like this, continue our dialogue, participate in the forums, get to your Rett clinics to be seen and known by the specialists, and and advocate, write those letters to your representatives, and encourage an investment, a federal level of investment of research in the United States. I also want to thank all of our international families for coming here today and spending time with us, and hope that your efforts of advocacy in your countries will also result in research and support and interventions for your children. This really knows no boundary. If I can, I just want to thank Dr. Suter. I know you are extremely busy, and the fact that you took the time today to prepare the presentation and turn your webcam on and make yourself available today and at all times to our families really gives us great hope on our journeys.
My pleasure. Thank you. Okay.
Thank you.
Bye, everyone.
Bye-bye, Dr. Suter. And Kate, Ashley, thank you for being there for families everywhere. We know you don't have all the answers, but as we share ourselves and our stories, these answers will, the questions will get answered in time. So thank you very much. And I hope that Colin and Parker continue to do so well, and